Hello, everybody. Thank you for joining me today. And I'm going to talk to you today about Dermoscopy Mastermind games. I'd like you all to join me in this journey in order to be able to gain more experience in the field of dermoscopy. Okay, as you all know, skin, our daily practice and passion, is the largest and heaviest organ of the body. And that's what we see by the best magnifying glass ever. But what happens deep inside is really more than what appears on the surface. That's why we need diagnosis at its most precise point by multiple modalities. In our practice, we start by history taking, proper examination, using visual aid devices, and this is the step where the dermoscope plays its role. We can also get the assistance by performing bedside tests or ordering laboratory investigations in order to be able to reach a proper diagnosis. The visual aid devices did not start by the dermoscope. It started by magnifying glasses, passed by the Wood's light, and now we are using dermoscopes. But why is the dermoscope really important? Initially, because the ability to early detect skin cancers, saving lives. But afterwards, I currently use it in literally examining every skin lesion. And thanks to the invention of polarized light and proper utilization of cross-polarization of light in dermoscopes, we are now able to have insight of what's going deep in the skin down to the depth of almost 1.5 millimeters. If we search the Medline database using the PubMed search engine, we'll find that there are 6,400 papers published on dermoscopy. And almost half of that was published in the last 5 years. So there is really growing interest in this field despite the presence of the COVID-19 pandemic. I'll start by quoting this paper that mentioned what I just mentioned, that the dermoscope is currently an irreplaceable clinical tool used for the evaluation of virtually every skin lesion. And I'll say, also mentioned in another paper, that time in the clinic spent with a dermoscopy expert was reported to be the most effective method of teaching. And this was stated by the US dermatology residents in a survey, which was published 4 years ago. So that's me before starting to use dermoscopy more than 2 decades ago. And that's me nowadays, quite confident of what I'm achieving in my practice. Dermoscopes has many shapes, many manufacturers, many magnifying powers, and many softwares as well that has aided dermatologists and general practitioners all over the years to reach proper diagnosis. But what's really new is the introduction of artificial intelligence in the field of dermoscopy. And what we are going to feel like today, as if we are sitting with a dermoscopy expert in the clinic, to be able to get the best way of teaching of dermoscopy. So let's start our mastermind games. And today's games consists of 11 scenarios and 29 questions for you to answer. For each question, I'll give you 20 seconds in order to be able to answer, and then we will discuss your answers together. So get your paper and pen and let's start it. In the first scenario, we have this novice junior dermatologist who is clinically confident but is asking your opinion to make sure. And he brings this adult male with multiple nevi, or we don't know yet. So let's have a look at this pigmented lesion on his right palm. And what do you think? Is it a melanoma? Is it a nevus? Is it a hemorrhage? Or none of the above? And the clock is ticking. You have 10 seconds to answer. 8, 7, 6, 5, 4, 3, 2, and last. Okay, so this is a nevus. Why is it a nevus? Because if we have a closer look at the image, we can see that there is pigment present in a line and a line, and those lines are parallel. And if we assess the width of the line, we'll find that it's narrower than the non-pigmented line. So based on that, we can tell that these lines are the thin ones, which are the furrows of the volar aspect of palms and soles. That's like what we see at the fingerprint. And when the pigment lies in the furrow, this is the physiological appearance, the normal pattern, because this is a place where we can see more melanocytes overlying each other, so we can see more pigment. So any benign proliferation of melanocytes at this level will give us this parallel furrow pattern, and this is why this is a nevus. But this patient is suffering from another lesion on his sole. So what do you think? I think it's easy. It's pretty similar to the other one. It's even more clear without any disturbance of pigment surrounding the furrows. And you can understand now what I was just mentioning right away in the previous slide. This is a case of a nevus as well. But also he's suffering from a linear pigment in his nail apparatus. And we can call it linear melanonychia. And melanonychia can be either true or pseudo. So what do you think of this? Is it a nevus, melanoma, hemorrhage, or none of the above? Let's describe while you're thinking. This is a black-colored linear line that is regular at width and color since its start till its end, and this is called true melanonychia, meaning that there is true proliferation of melanocytes because of the black color. If it was gray in color, we would have said that this is due to activation of melanocytes, meaning that there is increased melanin, but no increase in the number of melanocytes. What is also interesting about this case, rather than the regularity, is that the proximal nail fold overlying this linear melanonychia, true melanonychia, is free of pigment. And this is exactly a subungual nevus. If we're thinking of melanoma, we would have seen more than one line, more than one color, irregularity, and pigment also in the proximal nail fold overlying the linear melanonychia, which is, if clinically evident, will be called the Hutchinson sign, and if dermoscopically evident, will be a micro-Hutchinson sign. Okay, now to another patient complaining of these chronic itchy papules of his left ankle of a few months duration. And this is the dermoscopic image. And what do you think? Is it a case of a pseudolymphoma, a lymphoma, a lichen planus, or none of the above? The clock is ticking. What do you think? Dermoscopically, please don't get some data from the clinical description of the case or the history I've just mentioned. But yes, it's C, as you thought of. It's a case of lichen planus. And we know that from the violaceous appearance of the background, and those Wickham's striae, those white intersecting lines that are hugged by those linear blood vessels surrounding the Wickham's striation, and also secondary to the chronic itching, there is also some subcorneal hemorrhage spots over there. Okay, now to this lady suffering from this painful nodule of few years duration. And this is the dermoscopic image. And what will you do for such a case? Will you go for short-term monitoring for 3 months? Will you excise and send for pathology? Will you reassure and dismiss? Or will you go for long-term monitoring after 12 months? What do you think? To reach that decision, you have to reach the diagnosis at first. So it's a case of dermatofibroma. So you can reassure and dismiss for sure, or refer to surgery if preferable. So what's the case in here? We can see that there is something like a pigment network that's surrounding the lesion with a mesh of white color inside giving like a reticulate pattern, which is the fibrosis, the fibrous element that is tethering the epidermis down to the underlying structures, and which gives clinically the dimpling sign. So this is the case of a dermatofibroma. Okay, in the second scenario, we get more experienced doctors who are going to get more advanced cases and ask our opinion on which one is true. And this is the nape of a 16-year-old lady, and she is suffering from those papules. What do you think? And what will you do? Short-term monitoring, excise and refer to pathology, reassure and dismiss, or treat? What's your opinion? Okay, we will go for treatment for sure, because this is a case of molluscum contagiosum over there, those dome-shaped, very well-defined raised papules with this central amplification and all those white molluscum bodies over there. This is a case of molluscum contagiosum. And the leg of this adult male, which had similar lesions all over his body. And this is the dermoscopic image. And what do you think? And what will be your next step? Will you go for short-term monitoring? Will you excise and send for pathology? Will you reassure and dismiss, or will you treat? I believe everybody will go for histopathological assessment for sure. Yes, because this is really hard to tell. But for a dermoscopy expert, you might be able to detect this double-walled white line, like a railway line at the periphery of the lesion, and this homogeneous center. And this is characteristic for cases of porokeratosis. But definitely you have to make sure by pathological assessment in such cases. Okay, now to this male suffering from this atrophic lesion with erosions over his left eyebrow and temple region for 6 years right now. So what do you think of this dermoscopic image? Are we dealing with a case of a DLE, a melanoma, a BCC, or an SCC? What do you think? Clock is ticking. Come on. Okay, I believe it's not that easy. As we see over here, there is two colors of the background. One is bluish and the other looks like whitish over here with normal skin afterwards. And the most characteristic thing is that we see those arbrizing thick blood vessels at the periphery and thin ones in the center. So let's gather all this info together, and we will find that we are dealing with a case of sclerosing basal cell carcinoma, where there is this bluish tinge over there, and this is due to the islands of basaloid cells with a variable degree of pigmentation, and this fibrosis over here, and yes, the characteristic arbrizing blood vessels, which are in sclerosing BCC, thick at the periphery and thin in the center. What about this 72 years old male with this pinkish small nodule lateral, just lateral to the left ala nasi? And we can see here two images taken by the same dermoscope, by the same camera, by the same physician, to the same lesion, but they look different. And which technique you think is more beneficial? The contact wet dermoscopy, the non-contact dry dermoscopy? Both techniques are beneficial, or none of them has given enough data. Contact dermoscopy, we apply the dermatoscope directly to the skin, and we apply pressure in order to blanch the blood vessels, and this is the one on the left. But in non-contact one, we can see blood vessels. And the appearance of these radially arranged linear blood vessels and the central keratin crust is characteristic of cases of keratoacanthoma. So the most beneficial technique in here was the non-contact dry technique used in the right image. Okay, now for the foot, dorsum of the foot of this 5-year-old boy with this pigmented lesion, and we have those two images over here. And what do you think? Which technique was more beneficial in such case? The one on the left or the one on the right? And what's the difference between those two? For the one on the right, we can see those lines that are arranged linearly at the periphery all over the lesion. But the one on the left, we miss those and see instead those scales. That's because this was a dry technique and this was a wet technique when we applied a drop of alcohol at over the lesion before we applied the dermoscope. In both cases, it was contact dermoscopy because no blood vessels was seen in such a case. And the more beneficial technique was the one on the right. And this is a case of a Reed's nevus, which is a pigmented Spitz nevus due to the linear arrangement of all those dark lines at the periphery. Okay, and now to this boy suffering from xeroderma pigmentosum. He's 15 years old with all those facial skin lesions. His eyes were free, thanks to God. And what do you think? Well, at this patient, we found 45 different basal cell carcinomas in his face, numerous lentigines, seborrheic keratosis for sure, and one unidentified lesion which was excised and sent for pathology. Okay, now for the third scenario, where we can get some clinically similar lesions but are dermoscopically different. We can call these lesions twins. And twins lesions can look innocent, can look vascular, they can look interesting, and can look pigmented as well. But similar ones are not our interest for today. Our interest is those which behave in a different fashion, like those ones. Okay, now let's go for the first two twin cases, those two gentlemen suffering from those two nodules on the occipital region of their scalps. And can you notice the difference? And which one is the acne keloidalis nuclei? The one on the left, the right, both, or none? Well, I believe it's the one on the right. Don't you agree? Because of this smooth surface and this tufting of hair over there. But on the left, there is papillomatous appearance of the lesion with dotted blood vessels embedded in this white stroma, and this is a wart indeed. Those two ladies with those two papules on the anterior aspect of their necks. The one on the left is red and the one on the right is brown. And what are your diagnoses? I'll give you some time to think it over, but remember the clock is ticking. So, what do you think? The one on the right is pretty innocent. It's a compound nevus with this diffuse brownish color, which is slightly accentuated perifollicularly, but it's a compound nevus. But the one on the left is quite different with this peculiar appearance, characteristic appearance of the serpiginously arranged dotted blood vessels, which is characteristic of the clear cell acanthoма. So the correct answer is C. Two naps of two young ladies, two erythematous patches, and this is the dermoscopic appearance. And which one is psoriasis? Classic differential diagnosis for such cases is seborrheic dermatitis versus psoriasis. So what do you think? Which one is psoriasis? The one on the right, correct. Yes, because of the appearance of this homogeneously arranged dotted blood vessels. But the one on the left, we see confluent appearance, patchy distribution of the blood vessels and confluent appearance of white and yellow scales. Okay, two trunks, two ladies. What do you think? And which one is the weirdest in your opinion? The one on the left or the one on the right? I'll pick the one on the right. You know why? Because this is a tick. This is not a skin lesion. This is a tick attached to the skin and sucking on the patient's blood. And you can see even the tick's excreta on the skin surrounding. But the one on the left is a classic seborrheic keratosis with this cerebriform appearance, sharp margination, and notching of the border as well. Now to the arms. Two ladies suffering from two small nodules, which look quite similar, but dermoscopically quite different. And what are your diagnoses for such cases? Clock is ticking, clock is ticking, clock is ticking. The one on the left is violaceous with this dark red and violaceous clots, and this is definitely a angiokeratoma. So the correct answer is B. The one on the right is the most difficult one among those to be diagnosed dermoscopically, because this is an aneurysmal or hemosiderotic dermatofibroma, which shows this rainbow pattern and confluence of the blue, yellow, orange, and red colors as well. But you can still notice the surrounding hyperpigmentation. Now to the forearms, and you see here the patches, which are quite similar, but dermoscopically they're different. And I believe this one is easy. But which one do you expect to improve faster, the one on the right or the left? The right is a classic lichen planus, as we just mentioned, but the one on the left is a patch of dermatitis, with similar findings seen to the seborrheic dermatitis patch seen on the nape of the lady in an earlier case. And definitely we are expecting the dermatitis to improve faster, which is the one on the left. And to those dystrophic nails of those two adult males, what do you think? Which one is more serious, the one on the left or the one on the right? Tick tock, tick tock, tick tock. What do you think? Which one is more serious? Or they're both fine? He can live with it. Okay. I'll say that the one on the right is more serious because this is a case of systemic sclerosis. How did I get that? Absence of blood vessels on the proximal nail fold. This is a sclerosed proximal nail fold, and this is characteristic of collagen disorders. But how can I tell it's systemic sclerosis? Back to the clinical, the sausage appearance of the fingers. This is systemic sclerosis. But the one on the left is actually a lichenoid nail dystrophy in a case of lichen planus. Okay, inner thighs of two ladies, similar lesions, quite different dermoscopically. And which one is amazing? Which one is spectacular? Which one do you think is better? Not from an artistic point of view, but from a dermatoscopic point of view. What do you think? Okay, I love the one on the left. I agree with those who love this, because this is called a noodle sign. And what's the noodle sign? These are confluent and overlapping burrows of the female sarcoptes scabiei. And what's amazing about this image, that it is just a single isolated lesion, which looks like Norwegian scabies. And this is really amazing. But the one on the right is secondary to chronic itching, and this is a case of lichen simplex chronicus. Now to the anterior part of the shin of the tibia of two adult ladies with this, let me say, a bit of orange or salmon color patches. Dermoscopically, they are very different, very different. You can witness the difference immediately. But which one do you think is a sarcoidal one? The one on the left? The one on the right? Both or none? Well, okay, I know this is not an easy one, so I'll answer right away. The one on the right might be a sarcoidal one. Why? Because it has an orange background characteristic for granulomas. It has white scales. It has arbrizing blood vessels. So it can be. But if we go back to the clinical aspect, It's on the shin of the tibia of an adult lady. This is a necrobiosis lipoidica. This is not a sarcoidosis, okay? But the one on the left is a case of a pigmented purpuric disorder or pigmented purpuric dermatosis. And if we go again back to the clinical and we see it, a single lesion of a young lady, this is a case of a lichen aureus. Okay, nose of ladies. The one on the left is in her sixth decade, and the one on the right is in her early 20s, third decade of life. And dermoscopically, they're different for sure. But what is the most important dermoscopic clue? The keratin scales, the blood vessels, the pigment, or the background color? What do you think? Okay, what I think is that on the one on the right, I cannot see anything rather than keratin or scales. So this has to be the answer for sure. But what about the diagnosis? Actually, the one on the left is a keratoacanthoma, as I described it earlier. But the one on the right was really very interesting, as I couldn't diagnose it by dermoscopy at first, but by pathology, it was a case of actinic keratosis in this young lady with this follicular hyperkeratinization you see in this yellow circle surrounded, the yellow clot surrounded by this white circle around it, and at different other parts of the lesion as well. Okay, still with the nose. And what's the most important dermoscopic clue over here? What do you think? Is it still keratin scales or blood vessels, pigment, or background color? And I go for background color for sure, because the others are not even present in the lesion. And the one on the left is a sarcoidal one. The orange background color is present. The one on the right shows this Demodex follicularum infestation, and it's a case of rosacea as well. Okay, cheeks, two young boys, two small nodules. The one on the left is a molluscum, central amplification, many molluscum bodies, very well defined border. And the one on the right with this diffuse orange color is a case of a juvenile xanthogranuloma. So I answered this one, actually. You have to see it first to be able to determine it. Okay, two young ladies, two different lesions on their cheeks. Tuck, tuck. Dermoscopy? Tuck, tuck. What do you think? What are the diagnoses? Are we dealing with a case of an epidermal verrucous nevus and a case of an acanthosis nigricans? Nevus comedonicus with erythromelanosis follicularis fasciae E. coli, Nevus comedonicus and a terra ferra formi, or an epidermal verrucous nevus and a terra firma formi. I forgot to mention that the one on the left is dating since birth, and the one on the right is acquired. Did it make a difference? I don't think so. But the one on the left with those open comedones is definitely a Nevus comedonicus. And the one on the right with just keratin and scales and dirt over there is a case of a terra firma formi on the face. Two middle-aged ladies with this diffuse pigmentation of the face. Dermoscopically, it's totally different. And what's the most important dermoscopic clue now? Yes, the pigment for sure. This violaceous color that is surrounding the follicular ostia and highlighting them is characteristic for cases of actinic lichen. But over here, it's a case of melasma with the dermal component in this tan color, and the epidermal component is this darker brownish color. Heel, and big toe. What do you think? Where is the melanoma? The one on the left, the one on the right, the one in the middle, or none of the above? Tick tock, tick tock, tick tock. What do you think? And to answer this one, I'll go for skin pairing first. The one in the center was a hematoma, and the one on the left is a plantar wart with those thrombosed blood vessels. And the one on the right is a melanoma with this parallel ridge pattern. that is quite opposite to the parallel furrow pattern that I have earlier shown, and with this confluence of colors in the center, which is the thickest part of the tumor. In the fourth scenario, we'll go for rare discoveries. And this is a palm of a 21-year-old male patient suffering from this roughness of 1 year duration. And this is by dermoscopy. In the same week, I met another 1-year-old boy suffering from similar condition, but all over his body and dating since birth. And those keratin spikes getting out of the skin were really very prominent in here, causing this roughness. And these were proved by pathology to be porokeratotic eccrine ostial and dermal ductal nevus. And this old male patient suffering from this zombie-like tumor, maybe, it looks like a zombie for me, located on his right zygoma for a few years now, and dermoscopically, there were multiple parts, not just structures of the lesion. It was formed actually of 4 tumors. It was a collision tumor. And what are the diagnoses for this collision tumor? SADEK, keratoacanthoma, cutaneous horn, a keratoacanthoma again, a nevus keratoacanthoma, cutaneous horn, and the keratoacanthoma, melanoma, SCC, cutaneous horn, and an SCC, SADEK, SCC, cutaneous horn, and a keratoacanthoma. The clock is ticking. What are you thinking? Let's see larger image. This is a cutaneous horn for sure. You can see it clearly over here. And this is a keratoacanthoma with the central keratin. And this is again a keratoacanthoma with the central keratin and the radially arranged linear blood vessels. And this one is a SADEK with those comedo-like and this sharply demarcated hyperpigmented brownish lesion. So the correct answer is A, SADEK, Ka, cutaneous horn, and Ka as well. Okay, and now for this male suffering from erythema on all the photosensitive exposed areas of his body. And this is by dermoscopy. You can see this sort of maybe pseudopoikiloderma, some hypers, some hypo, no atrophy, some blood vessels. It was not confirmed until biopsied, histopathologically assessed, and stained by Congo red to be examined by polarized light to get this apple green birefringence, and it was a primary cutaneous amyloidosis poikiloderma-like. In the fifth scenario, dermoscopy can reveal surprising findings, like this lady suffering from this almost erythrodermic change of her skin. Maybe it's pustular as well. That was the result of clinical images. Dermoscopically, at first, I could see nothing. Maybe some clues if someone has an expert eye. Still puzzling. What do you think? I believe it's quite clear right now. This is the barrow. This was a case of Norwegian scabies. And this 21-year-old male patient who presented suffering from whitish lesions of his abdomen of 1 year duration, not responding to treatment as fungal or as vitiligo. I could barely see those. These are the ones at macro image in order to tell you what he was complaining of. But actually with the examination, I could see some in his left shoulder rather than the stride, and more evident on the upper back. I went for dermoscopy, and this was the initial finding. I can tell that it's not clearly depigmented, but at one lesion, I could see what looked like comedones or follicular plugs. And at higher magnification, they were evident. So I was thinking, what if this is a case of an extragenital lichen sclerosis ethetrophicus? And yes, that was the correct answer. And I was really glad with what I achieved. And these are the pathological specimen slides showing that there is a sparse perivascular infiltrate and the collagen is not as thick as in earlier cases. So in the sixth scenario, where experienced doctors go for clinical dermoscopic correlation that builds up, in this 52-year-old lady suffering from this tumor of 6-month duration, and dermoscopically, that's what we could see. Lobulated nodule with blood vessels on the surface, which are different, which are irregular, which are polymorphous. And there are some deep bluish areas can be witnessed in other sites, also at the periphery. And this really looks ugly. There's something wrong with that. What's your diagnosis? Is it a nevus, a lymphoma, a melanoma, or a squamous cell carcinoma? What do you think? Tick tock, clock is ticking. What's your opinion? It's a melanoma, correct. Confluence of colors, irregular polymorphous blood vessels, bluish eccentric color at the periphery. This is a melanoma. In the seventh scenario, sometimes we can be misled by dermoscopy, but saved by pathology. Like this 56-year-old lady suffering from this lesion on her right cheek of 1 year duration. And what do you think? This is not an easy one. She also mentioned that she was healed by super potent topical steroid and then it recurred. So what's your diagnosis? Is it a case of squamous cell carcinoma, basal cell carcinoma, actinic keratosis, or lichen planus? Well, it's a case of BCC. Although we cannot see findings of BCC rather than the surface erosion, but it's a case of BCC. What about this lady suffering from this accentuated pigmentation in her flexures? And dermoscopically and clinically, my initial diagnosis was lichen pigmentosus. But what do you think? Is it really lichen planus pigmentosus? Or is it a case of MF? Is it a case of post-inflammatory hyperpigmentation? Or none of the above? This one is tough because we were saved by pathology again, and it was a case of mycosis fungoides. In the eighth scenario, Dr. House says that dermoscopy is helpless. Like in such male suffering from this ulcerated nodule of 2 years duration, and all we could see at that time was irregular polymorphous blood vessels, and this is not looking good. But we knew afterwards that this is a case of B-cell lymphoma. Like in such case of a male suffering from this diffuse reticulate hyperpigmentation of the trunk, dermoscopy could tell that this is just hyperpigmentation, but nothing more, no more data. Also in that lady, similar case, similar thing, and both were diagnosed by pathology as reticulate and confluent papillomatosis. In the ninth scenario at the aesthetic clinic, I'll tell you my experience, which is really very important in practice, that we shall use the polarized contact dermoscopy and the non-polarized non-contact dermoscopy to properly assess the quality of the skin. As over here, you see this was the clinical image, and dermoscopically on the left, we can see the details of the nevi by the contact polarized dermoscopy, and you can see the details of the wrinkles by the non-contact, non-polarized dermoscopy. Likewise, in this finding as well, on the right, the non-contact, non-polarized, and on the left, the contact polarized. Similarly here, on the left, the contact polarized, and on the right, the non-contact, non-polarized. So for anyone to assess the skin properly in any case of skin photoaging, you shall go for combination of both contact polarized and non-contact, non-polarized. Similarly, on the forehead, we can also witness the difference. The one on the left is with contact polarized, and on the right with non-contact, non-polarized. And if you'd like to know more about what we have done before, you can go for our paper and have a look over there. In the 10th scenario, we can go for choice of treatment or follow-up by dermoscopy, me and my team, like this male who was suffering from a BCC on the nose. And in spite of being a high-risk BCC, he refused surgical excision and he went for cryo. And we can see after 1 session, 2 sessions, 3 sessions, and finally we can tell that he's okay. In 6-month follow-up, he was clear. In 12-month follow-up, he was clear, but at 18th month follow-up, there was recurrence and he couldn't refuse surgery at that time. This one was okay with surgery, and he took it off and placed a skin graft, a complete thickness skin graft. And we can also use the dermoscope to assess the periphery and the sutured graft for any residue of BCC. And it was clear in such patients with no findings of basal cell carcinoma down there. And finally, in cases of field cancerization, to detect where to specifically treat actinic keratosis, and the appearance of those white rosettes is characteristic for the actinic keratosis, though it can appear with other hyperkeratotic lesions. But when we see it in such a patient suffering from field cancerization, we have to know that this is most probably site of actinic keratosis. By this, I end my presentation, and I thank you for your attendance.